Welcome back to Endo in a Bite, the podcast where the 2025 Thyroid Cancer Management Guidelines are broken down into simple, clear lessons. Today, we are finishing up our journey through the 2025 Thyroid Cancer Management Guidelines. In this final part, we are covering recommendations 73 through 84. These focus on what happens when thyroid cancer is more advanced, what to do if someone is pregnant, and how patients and families can get the long-term support they need. Let's begin. Immune checkpoint inhibitors or other forms of immunotherapy may be offered in selected cases, such as when tumors harbor a high tumor mutational burden or are mismatch repair deficient. Redifferentiation by mitogen-activated protein kinase pathway blockade in patients with progressive radioactive iodine refractory differentiated thyroid cancer that carries targetable mutations may be considered in carefully selected cases. Clinical trial enrollment is strongly encouraged whenever possible. Redifferentiation approaches are not recommended as adjuvant radioactive iodine treatment in patients with high-risk, non-gene-selected differentiated thyroid cancer. Cytotoxic chemotherapy may be considered for patients with radioactive iodine refractory differentiated thyroid cancer who have metastatic disease that is rapidly progressive, symptomatic, or imminently threatening, and cannot be controlled with other approaches. For patients with radioactive iodine refractory differentiated thyroid cancer who have solitary or limited metastatic disease, meaning 2 to 5 lesions, focal ablative therapy may be considered. The best treatment strategy in these cases is often determined through a multidisciplinary team discussion. For patients with symptomatic radioactive iodine refractory differentiated thyroid cancer, local treatment is recommended. Surgery, radiotherapy, and percutaneous thermoablative techniques are available to manage individual symptomatic disease sites. In patients with radioactive iodine refractory differentiated thyroid cancer who have symptomatic or multiple bone metastases, treatment with a bone-modifying agent is recommended to decrease the risk of skeletal-related events. A dosing schedule of every 3 months may be considered, as it can reduce the risk of side effects such as osteonecrosis of the jaw compared with monthly dosing, although it may also increase the chance of symptomatic skeletal events. For central nervous system metastases, the mainstays of therapy are surgical resection and stereotactic body radiation therapy. Radioactive iodine can be considered if central nervous system metastases concentrate radioactive iodine. If radioactive iodine is planned, stereotactic body radiation therapy and concomitant glucocorticoid therapy are recommended prior to radioactive iodine therapy to minimize the effects of a potential TSH-induced increase in tumor size and radioactive iodine-induced inflammatory response. Patients should be counseled about the option of enrolling in clinical trials, taking into account eligibility criteria and the likelihood of benefit. Clinicians who are considering referral for trial participation should carefully review treatment options and trial eligibility, ideally through direct discussion with trial center staff and review of information available on the website clinicaltrials.gov. Pregnancy brings its own unique considerations. In most pregnant patients, surgery for differentiated thyroid cancer can safely be delayed until after delivery. The exception is the rare patient in whom there is concern for significant progression of disease. If surgery is needed during pregnancy, the safest time is in the second trimester. For patients diagnosed with differentiated thyroid cancer during pregnancy, monitoring with neck ultrasound at least once in the early second trimester and more often if there are clinical concerns is appropriate. In selected cases, cross-sectional imaging with MRI may be performed. Imaging studies that use ionizing radiation should be avoided and reserved only for exceptional circumstances. The TSH goal during pregnancy is generally the same as before conception. Levothyroxine dose may be adjusted to allow for less suppression of TSH if there are concerns that excess levothyroxine could negatively affect the pregnancy. TSH should be checked about every 4 weeks until 16 to 20 weeks of gestation, and at least once again between 26 and 32 weeks of gestation. For pregnant patients who have an incomplete response to therapy, continued monitoring with neck ultrasound and serum thyroglobulin is appropriate. If cross-sectional imaging is required, MRI is the method of choice. Patients who are in an excellent response or indeterminate response category should be followed in the same way as non-pregnant patients. And finally, long-term support and follow-up. Cancer care does not end when surgery or treatment stops. Patients need ongoing support. That includes watching for possible long-term side effects of treatment, addressing the financial stress that can come with cancer care, and just as importantly, ensuring that patients and families receive emotional and social support. Living with cancer can bring anxiety, stress, and major life changes. Counseling, support groups, and community programs can make a tremendous difference in helping people feel less alone. So let us recap. Immunotherapy may be used in carefully selected patients, and redifferentiation with mitogen-activated protein kinase pathway blockade can be considered when targetable disease is present, ideally in clinical trials. Cytotoxic chemotherapy is reserved for patients with aggressive or symptomatic disease that cannot be managed otherwise. Focal ablation may be offered for patients with just a few metastases, while local surgery or radiotherapy can relieve symptoms. Bone-modifying agents are helpful in those with painful or multiple bone metastases. For central nervous system disease, surgery or stereotactic radiation are the main options, and if the lesions take up radioactive iodine, it may be added, but only after giving glucocorticoids to reduce swelling. Clinical trial enrollment should be strongly encouraged whenever possible. In pregnancy, surgery is usually delayed until after delivery, with the second trimester being the safest time if an operation is needed. Ultrasound and MRI are the monitoring tools of choice, and TSH goals remain the same as before pregnancy. Finally, it is important to monitor for long-term side effects, to address the financial burden of care, and to recognize the psychosocial impact of thyroid cancer by guiding patients to appropriate support. Together, we have worked through all 84 recommendations step by step and bite by bite. Thank you so much for letting me walk this journey with you. If you would like summaries sent straight to your inbox, visit easyendoprep.com and sign up for the weekly newsletter. Remember, consistency is the key to mastering these guidelines. We have now made sense of all 84 recommendations, one bite at a time.